Alright, so now trauma and injury. This is kind of where we're going to start here with the types of injuries to the skeletal system that you can have. That's not just skeletal, musculoskeletal. Alright, because we got muscles and skeletal and the bones all connected, right? So first we're going to talk about strains. Okay. A strain is the excessive stretching of a muscle or tendon. Surgical intervention may be required for severe strains that cause muscle or tendon rupture. This is usually what you hear referred to as a pulled muscle. You got an athlete or whatever, they pulled their hamstring or they pulled whatever muscle. They really had a strained muscle. That's what that's called. Or I guess in more medical terminology type stuff. There's different classifications. And you will hear this from time to time. The different classifications: a first degree or mild strain is when there's mild inflammation with little bleeding and bruising. Alright, second degree or moderate strain involves tearing of the muscle or tendon fibers without complete disruption. So you don't have it completely torn to where it's not intact to some degree. Like the third degree. Third degree strain or third degree severe muscle strain or tendon strain is when you have a rupture of the muscle or tendon with complete separation of muscle from muscle or from muscle from tendon or tendon from bone. Alright, so muscle separated from muscle, muscle separated from tendon, or tendon separated from bone. Yeah, I mean, well, and they're talking about a strain, and that's, yeah, I mean, that's basically it. It's just a third degree. If you've torn it completely, then yeah, it's going to be a third degree. You get caught, a lot of times you'll hear, pulled muscle, and that, obviously that's different than, an ACL or something like that, but it kind of falls in that strain category. Alright, management of a strain, obviously it's going to depend on the severity, but management is going to include cold application for the first 24 to 48 hours, and after that, heat applications, and I don't like the way this is worded, but you're going to elevate the extremity regardless. First 24, 48, whatever, you're going to elevate the extremity. The heat applications will be after that first 48. Alright, activity is going to be limited depending on the severity. And then medications are going to be ordered to manage swelling and then also pain. So anti-inflammatories, muscle relaxants, all that kind of stuff. Alright, next thing, we've got a sprain. Our sprain is going to be excessive stretching of a ligament. Okay, so when we talk about a sprain, we're dealing with ligaments. Again, the treatment is going to be based on severity. And there's different degrees of a sprain. First degree or a mild sprain, you got RICE. Rest, ice, compression, and elevation. And you'll see that the whole RICE acronym, that's a common treatment for a lot of these musculoskeletal injuries. All right, second degree or moderate sprain requires immobilization and limited weight bearing, in addition to the rest, ice, compression, and elevation. And finally, the severe or third degree strain, again, you do the rest, ice, compression, and elevation. Also, you're going to have immobilization, usually 4 to 6 weeks or more, and it may require surgery for repair. These are all kind of general terms. I mean, these are general treatments. These are general, what you would typically see. That's kind of the way that works. All right, next, we've got our dislocations. All right, our dislocation, a joint dislocation occurs when the ends of 2 or more bones are moved away from each other. Okay, bones that should be in close proximity are moved away. It occurs at the joint, and it results from injury to the ligaments that hold the bones together. Okay, some of the common joints that you'll see affected include shoulders, hips, knees, and fingers. Alright, so the manifestations, obviously, you're going to have pain, immobility, and this is talking about immobility related to that joint. So whatever that joint is, it doesn't have the normal range of motion. It doesn't have the normal movement. If it's a shoulder, which commonly you'll see the shoulder dislocations, you're not going to have the same range of motion. You don't have that same ability to rotate the arm, at least not with some severe pain. Usually if it's a pretty severe dislocation, you don't have the ability to move in any direction because that joint is not there to move that extremity. All right. Physically, you'll see an alteration. You'll see, and look for symmetry. Okay, especially, I kind of go back to shoulders. That's typically what you see with these dislocations. You can physically look at the two shoulders in comparison and see that one has got some deformity to it. There's a change in the contour. It's not, physically you can see it. As you move your hand over it, you can rub your hand, move your hand over it, and you'll feel a change in that contour. Also, deviation in the length of the extremity. This is common, and I know y'all talked about the peds part. A baby has a hip dislocation, and you can look and see if you have one leg that's longer or longer than the other. You got to start doing some investigating, right? There's a possible joint deformity there. Something's happened. And then also abnormal rotation of the extremity. So basically just, you may have some function in one direction or another, but if you don't have the ability to rotate in all of the normal directions for that joint, then we've got something wrong. Alright, so what's our nursing intervention? Well, first, pain relief, joint support, and protection. We don't want any more damage to occur unless it's, I guess, dislocation of the neck. I don't know. I mean, you're not going to have to worry as much. Now, obviously, if the patient's in respiratory distress, that's an issue, but you're not quite as worried there if you're talking about a dislocation of a joint. But pain relief is going to be a big priority, and joint support and protection. You want to immobilize. If a patient has a separated shoulder or even some kind of joint issue, immobilize until they can figure out what's going on with it. Patient comes in complaining of a shoulder injury, you're not going to move them around or guide them with that shoulder or guide them with that arm. You immobilize until they can actually get a look at it. You prepare for immediate joint reduction they're going to try to get the joint reduced and back in place as quickly as possible. If they can do it manually, they will. It may be that they put it back in place, they reduce it, but it slides back out. Well, we've got a problem with our ligament, okay? Our structures that are holding that bone in place, if they've been stretched to the point where they're not doing their job and holding it in place, then it may just slide right back out. Then they're probably going to have to go in and surgically repair. You also, and even if they're doing a close reduction, get the pain medicine to them, as quick as you can, even before they do the reduction. A lot of times, especially, I know the ortho docs, they got a lot of patients that they almost get desensitized to the pain zone for a lot. They say, well, we can just pop it in place real quick. Well, let's get them some pain medicine, then you can do it. You have to kind of encourage that a little bit. Be an advocate for your patients. They want to just do it real quick. Oh, yeah, it's just going to hurt for a minute. We'll just pop it back in place. Okay. Yeah, you're right. Sometimes it takes a little more manipulation. Yeah, it's going to be hospital, physician, all that. If you're in an ER setting, you're probably going to have standard orders. Standing orders that patient comes in, you've got a protocol to follow. The key is you've got that order, though. You can't just go off, well, this patient looks like they're hurting, so I'm going to use my nursing judgment and off of my nursing license go and give them some morphine. No, you can't do that. You've got to go off of that standing order, or you've got to go off of that physician order or practitioner order, whoever, depending on states and all that good stuff. But you got to have that order to do that. But you can call and encourage it. Sometimes you can be more persuasive than others. But so open versus closed reduction. Again, open basically means they have to open them up and do the reduction, or reduce the joint or fracture or whatever it is surgically with an open incision. Closed reduction, well, they can pop it back in place without opening it up. Sometimes it takes a couple of attempts, and they have to do it with radiology. They're going to verify it. They're going to take an image before, and then they're going to reduce, and then they're going to take another image after, make sure it's where they need it to be. And we're kind of moving into fractures a little bit, but that's kind of the way that goes. But if they are using sedation, and like you said, in the ER, commonly they'll do sedation, conscious sedation, local sedation, or not sedation, but local anesthetic, that sort of thing, and then just do it there at the bedside or in the ER. All right, and then finally, implement activity restrictions and general range of motion as ordered. Okay. Follow your orders as far as activity goes. I mean, and we had standing orders, not in terms of medicine, but we just had kind of standing protocols that we followed. You've got a traction patient coming in. We had ortho techs that would set it up. We had certain things that we could do with the traction. We had certain things we could do with the cast care. Maybe outside of the nursing scope, but we had orders and protocols that were in place that gave us that permission or gave us that order. All right, so that's our dislocations. Now we'll move into fractures. Fractures is fairly in depth, and should be. There's a lot of stuff dealing with fracture. But quite simply, fracture is an interruption in the continuity of a bone that often affects mobility and sensation. There's different classifications that we'll put a fracture in. First deals with the extent of the break. A complete fracture is when the break occurs across the entire width of the bone. Okay, so that means if I've got a femur fracture, a complete femur fracture means completely broken and one side is separated from the other. Okay, that's a complete. That's not quite as common. It is, well, I say that. Yeah, it's fairly common. But that's a complete. The incomplete, probably more often you'll see that where they come in, they reduce it, get it back in place, and then they're sending them home. Just depends on the severity, obviously. But incomplete, it does not completely divide the bone into two portions. All right, the next classification is going to deal with the extent of tissue damage. Okay, and this deals with whether you got a bone sticking out of the skin or not. An open or compound fracture is when the skin is broken over the fracture. So the fracture occurs, and the fragment or a piece of that bone punctures the skin. What does that alone put the patient at more risk of? Infection. Okay, we've opened it up to the outer environment. Okay, outer everything else. I mean, all the infections and things that go along with that. Dirt, rock, pavement, all that kind of stuff. That immediately exposes them to more of a risk for infection. A closed or simple break or fracture is when the skin integrity is intact. It didn't open it up until we have to go in and do a surgery, which then opens it up. But hopefully they can reduce it. Closed reduction. All right. We also look at the cause of the fracture. All right. A pathologic or spontaneous fracture is when there wasn't a lot that caused it. I mean, as far as there's not a lot of trauma that goes into it. Usually minimal trauma, the fracture caused by weakness due to disease. A normal everyday act should not cause a fracture. For instance, if you've got a patient that walking down the stairs and they don't fall, but suddenly, their leg gives out and the fracture occurs prior to the fall. If you have, what's a good example? Okay, an elderly patient. There you go. You're helping to move an elderly patient, and they have a fracture, or they have a hip fracture, or even an arm fracture, or something like that, with a normal everyday act that is not putting excessive trauma on that bone or that skeletal structure. So that's pathologic. Fatigue or stress fracture results from excessive strain on a bone. Commonly, you'll see these in the feet. Runners commonly get stress fractures. It's repetitive, excessive impact. It's not like it's one hard blow. It's a lot of continuous blows. And then finally, you've got a compression fracture. This is when force is applied to a long axis of the calcaneus bone. This is what you typically see. This is a patient that falls on their arm and they have an arm fracture, or they have a car accident and they break a femur. There's a lot of force that has to be applied to that femur to break it, unless it's pathologic, unless there's some problem interiorly with that bone or that bone structure. And then the last type or last classification is going to be the type of fracture, and this is what you typically see. I guess you typically hear of the different types of fractures. All right, first, this is a closed, non-displaced fracture. There's a fracture, disruption of the bone continuity, but hey, it's already reduced and back in place. All they're going to do is just put a cast on it, if it's something that can be casted. All right, next, you've got an open compound fracture. Okay, so this has broken the integrity of the skin. All right, next you've got a comminuted or fragmented fracture. Usually some type of crush injury, something like that, that's caused the bone to fragment. These are a lot harder to Usually they got to put some kind of hardware in place, because at this point, I mean, if you look, there's a gap here, right? There's a gap from one end to the other, so they've got to put something in place to fill that gap. It's not like they can just put a cast on that arm and everything's going to kind of grow back. It will, but it's not going to grow back with that space in between. Does that make sense? It's going to grow back compacted, and you lose half your arm, or you lose half of that that space there. And then you got all kinds of problems. Do what? What do you mean they don't fill it? They'd probably put some kind of rod or hardware. Yeah, they'd have to put something in there to connect one end to the other inside the bone, and then it would grow back around that rod. All right, then you got a displaced fracture. This is similar to it's a closed fracture. It's when you've got it's usually you're going to have an obvious deformity, but it hasn't broken the skin. Okay. Now this could quickly become an open fracture if you don't immobilize it. If you don't, contain or immobilize the injury, then it could quickly become an open if one of those fragments of bone pierces the skin. But this one, they're going to pull it and move it back in place. Usually manual reduction is what they would use there. All right. Down here we've got an oblique fracture. Oblique fracture, again, it does not completely separate the two bone structures, and it goes more of the length of the bone versus the width. All right. Next, you've got a spiral fracture. Spiral fractures are usually going to be seen with children, and it's a pretty good sign of potential abuse or something like that. At least that's one of those signs that they'll look at. Okay, it's not always. You can have children that are going to twist, and I know my wife called me one day. I was working at Children's, and she calls me and says, "I think Taylor, my son, separated his elbow, an elbow separation," and we ended up finding out it was nursemaid's elbow. I don't know if you've heard of that. Y'all may have talked about that. Well, I'm working on the floor. We never saw the nursemaids because they treated them and sent them home. I didn't even know what it was. I'd been working there 4 years in orthopedics. And so I said, is he not moving it? No, he can't move it at all. And when she's trying to move it, and it really wouldn't move. So it was contracted because it was out of place. So we bring him in. So I've called, one of the ortho docs, and I've got him kind of on standby, and we still had to wait a long time, but still, that's kind of how it goes. And come to find out, when one of the ER nurses, she went to go check his blood pressure, and she was able to just kind of reduce it when she just did a range of motion, basically. She had seen it done, so she just did it. But anyway, so it was just a nice, simple thing. My wife was holding his hand, and he decided he wasn't going to go where she wanted him to go, and so he hit the floor. Ended up separating his, the nursemaid's elbow. So you have to kind of consider that. Be aware of the signs that could indicate potential abuse. And I know this is not pediatrics, but it could be going on with an elderly patient as well. But spiral fracture is one of those indicators. Also, we've got impacted fracture. What do you think impacted fracture is going to be? There's a fracture that occurs as a result of some kind of blow. It's like, I guess if you fell, landed hard on your elbow with that vertical compression, okay? Also, you'll see this a lot with the spine, spinal vertebral fractures. You'll see those impacted, impact fractures, compression fractures. I don't even think we have compression on here, but that's similar to a compression fracture. And then finally, green stick. And green stick is almost always going to be, it's either a pediatric patient with underdeveloped skeletal structure or somebody with some type of pathologic issue causes that green stick fracture. This is, I think I've got, here's a picture. It's similar to like a fragmented. You take a limb and just try to break it, but it's not a dead limb. It's a limb that's nice and green. You can break it, but it's not going to break all the way through. It's similar to that. That's another story. I had one of my neighbors. I'd been working there for a while. She knew I was in orthopedics, and all of a sudden we hear her moaning next door. She was an older lady, and we heard her moaning, and it kind of kept getting closer and closer, and we thought, well, what's going on? So we go look, and I look outside, and she's kind of dragging herself over to my door. So I run out there to see what's going on. Well, she had fallen, and she had hurt her leg a little bit, but her arm was obviously broke. I mean, it was an obvious forearm fracture. And so I go in and I told her, I said, look, I said, it's broken. I said, we got to do something to immobilize, because I knew if we didn't, she was going to end up having a break of the skin before she got to the hospital. So I'm looking around thinking, okay, what can I do to immobilize this arm? So I look over, my wife's got these little small bamboo placemats in the kitchen. Look over, I said, that's a perfect immobilizer splint right there. So I grabbed that and I just taped it up. But that's got to be your first, the first thing you do is immobilize. I didn't reduce it. I didn't put it back in place. Because for one, you don't do that until you've seen the films. But you just got to immobilize to prevent that further damage. So that needs to be as a nurse. You're out at the ball field, or you're out at, Walmart, and somebody goes crazy on Thanksgiving, Black Friday shopping. Grab someone to immobilize. Okay, immobilize the extremity so that it can't have further damage to occur. All right. Magazines, yeah, anything that's got some structure to it, and you don't want it to be. Well, what do you not want it to do? Yeah, you don't want it to cut off circulation. So you got to make sure it's not too tight. But yeah, I mean you got to immobilize because you don't want that closed fracture to become an open fracture. And she ended up having a both bone forearm fracture. It was pretty rough. But then when she got there, she realized she also had, it was either hip or a femur fracture of some type. We weren't even messing with that. It was obvious that she had an arm fracture, but she was in bad shape. I got back to work, and one of the physicians down in Birmingham, they'd rotate from UAB to children's and all over. I mean, the same ortho docs, they didn't just do peds or adults, they went all over. He comes in, he said, you got any placemat immobilizers? What are you talking about? He said, yeah, I saw your work the other day. When she came in, I saw your placemat immobilizer. I said, yeah, that was me. He said, did the job. So you just have to find something that works. Jones. I'm not familiar with that one. Is it a type of stress fracture or? Probably not a stress fracture. Interesting. Huh. Yeah, and you can have, and a lot of times they'll have different terminology and different words and phrases for these different types. That sounds like a very, very specialized, that Jones fracture must occur at that one specific spot. So yeah, you got, all right, so let's talk about the symptoms. You got some obvious symptoms. Pain, the patient's had a fracture, they're usually going to be in pain. I don't know if any of you, I'm sure in this group, everybody's had or not everybody, but you've all had a fracture or seen a fracture or known somebody that had a fracture. But pain's going to be a big one. Okay, when you're dealing with the bones, That's one of the most painful types of procedures that you'll have. So pain, loss of function, and I'm going to add this deformity to it. I mean, obviously, if you have a deformity, if you can visually look at, a fracture. Now, the key is you don't always have a deformity. You don't always have an obvious sign that a fracture has occurred. It's a lot easier to diagnose it when it's obvious. It's self-explanatory, but when it's apparent, when you see a bone, it's a fracture. Some of these videos of athletes that have these awful, gruesome injuries, just terrible. You can see, especially when you see the bone. Also edema, and not edema, but edema and ecchymosis. You don't always necessarily have a ton of swelling. If it's a bad fracture, you're going to have swelling. Okay. The only reason I'm saying some of that is you don't always know whether a fracture has occurred. You can't just look at every single fracture and be able to diagnose it right away. It's going to take some type of x-ray or visualization in most cases to accurately diagnose. Also, false motion, crepitus, and then it's just not, when a patient tries to move it, it's not moving. Okay? You'll hear of these really bad breaks. You'll see patients that are trying to move the leg, or they're trying to move the arm, or they're trying to do something, some kind of motion, and it's not going anywhere. Usually those are pretty bad ones. And then also if the bone is visible, obviously, with the deformity. All right, so here's how the healing occurs. Okay, you've got different stages of healing. You've got hematoma formation. Okay, so there's a purpose and there's a reason for the bleeding to occur. You don't want excessive bleeding, but that hematoma, that bruising, and a lot of times you'll see it immediately, and that's because that healing process has already started. Second, you've got granulation tissue formation. The site of the hematoma, as the blood has formed around that fracture, it starts that healing process, basically. Third, you've got callus formation. It's the next step. 4, ossification. Actually, the bone starts to grow. And then finally, consolidation and remodeling. It corrects itself. It almost shaves off the pieces that don't need to be there. They kind of, it grows in the right way, I guess. Now, the fractures, as I said, they begin almost immediately, so that the body can return to homeostasis. We talked about homeostasis. That's the body's regulation process. It's trying to get back to homeostasis as quickly as possible. In young, healthy adults, a simple fracture healing takes about 4 to 6 weeks. Now, this is a typical simple fracture, okay? One that they're able to reduce without surgery and put a cast on it. Okay. Now, a fracture in an older adult takes longer to heal. Part of this is they lose the bone regeneration process. They lose a lot of that, really the homeostatic response. It just kind of slows it down a little bit. Patients greater than 70 years old may require 3 to 6 months for that same simple fracture. Again, it depends on the patient, the condition, the nutritional status, all that good stuff. All right, so some of the complications, and that kind of goes into that some of the complications that you need to look for following a fracture. First, you've got hypovolemic shock. Fat embolism. All right, does anybody know what the earliest sign of fat embolism is? Anybody? I think I heard some Usually going to be altered mental status. Okay? The earliest manifestation of fat embolism is going to be altered mental status. And why is that called, or what causes that? Hypoxia, yeah. Hypoxia. Caused by low arterial oxygen levels. Dyspnea and chest pain may follow, or even occur right at the same time. Dyspnea, chest pain, altered mental status. If you've got a patient that's had a fracture, you immediately go to that. You immediately suspect, hey, we could have had fat embolism or really any type of clot that could have slipped or moved, any type of emboli that occurs. All right, petechiae and macular measles-like rash may also occur, commonly over the neck, the upper arms, chest, and abdomen. So you need me to repeat that? All right, so you'll commonly see petechiae, also a macular measles-like rash. These are still signs of fat embolism. And then this rash is going to occur over the neck, the upper arms, the chest, and the abdomen. This is a classic manifestation, but it's usually a late sign. Okay, so if you see the rash, it's usually a later sign. You're going to see, or you're going to have the altered mental status, chest pain, and dyspnea first, usually. The rash. That rash starts to develop. It's a classic sign. It's something that will usually occur, almost always, but it's a later sign. All right, so, and that's fat and the thromboembolism. I mean, both of those are going to be, when you've got the emboli that's moved, those are the signs that you'll see. Also, infection and osteomyelitis can occur. Anytime you got the fracture, anytime you have that interruption in the bone, you're likely, or not likely, it's possible that you could have an infection develop. All right. Also, delayed union. I got a guess on what delayed union is. It's slow healing. Slow healing of that bone. And then it could end up being non-union, where it just does not grow back appropriately. All right, avascular necrosis of the bone. What's avascular necrosis? I got a guess on that one. Yeah, when you just don't have blood supply to the bone, and it dies, the tissue dies. Other complications: ischemic paralysis of contractures, Volkmann's contracture, which is another type of the contracture, and then compartment syndrome. Compartment syndrome is a big one, and you really, really, really have to monitor for the compartments. Okay. Compartments is when you've got the fluid shifting to the point where it's cutting off circulation. You lose circulation to that extremity. Anytime you've got a patient in a splint, in a cast, even if it's open, not open, but if you have an extremity that's been operated on, you've got to closely monitor for compartment syndrome. And the signs are pretty obvious. Obviously the swelling, you're going to have extreme swelling, but the patient is going to let you know anytime you get near that extremity. We had a patient that was actually following a spinal fusion, which you almost never see this with a spinal fusion. You could walk into the room and he's in a dead sleep, and you touch his bed and he screams at you. It's just excruciating pain and pressure. That's the big thing, is the pressure. They've got to relieve the pressure, or that extremity can die. Cuts off circulation, and you can have cell death. Take a big long needle. That's it. Now, that's diagnostic. When it's elevated like that, then they could do the fasciotomy, where they cut pieces of the muscle and the tissues away, to open it up to allow it to drain all that fluid, relieve that pressure. But yeah, we had this. I don't know what they call this, compartment syndrome checker, I guess. But it was this big giant long needle, and it went in this device, and they would push it into the area where the compartment syndrome was suspected, and it would tell you the pressure. So it gave them an actual reading on what the pressure was. And I could say, yeah, we got some compartments, so we got to take them down for the fasciotomy. Usually it doesn't have to get to compartments. If you start checking it early, if you keep it elevated, keep that extremity elevated, there are times when you just can't prevent it. But usually you can kind of prevent it from doing that. Also, we got changes in reflexes, post-traumatic arthritis, and it just the joint or the whatever just doesn't work like it should. And then also the DVTs we've talked about. Nutritional considerations are very, very important. Okay, high protein diets are really, really important. Also, encourage fluid intake. What do we commonly give with a fracture when they hurt? Pain medicines, typically some type of narcotic pain medicine, opioid pain medicine. What's that going to cause? Constipation, 9 times out of 10. So if they don't go ahead and start them on Colace, or they don't start them on some type of laxative or whatever, stool softener, they're probably going to get some type of constipation if they have prolonged opioid use. So at the very, very least, encourage fluid intake. Encourage fluid intake. Sometimes you can limit that constipation risk just by doing that. Okay, so we've talked about a little bit of this, but the emergency treatments outside of the hospital. Number one, splint them where they lie. Okay, don't try to get them up, move them around too much. If they've got an obvious fracture or an obvious deformity, get the splint on there. Immobilize the joints above and below the fracture. Maintain as normal a body alignment as possible. And all this is done to prevent further damage to the bone and the tissue, soft tissue. But it also helps with pain. I mean, if the bone is not immobilized and it's moving, there's a lot more pain involved. And then also we don't want to lose circulation as well, which I guess that's probably going to be number one. We don't want to lose circulation foremost. All right, so once they make it to the clinic or the hospital or the emergency room, whatever, you want to assess and document complaints of tingling, numbness, and burning. These neurovascular issues. You're constantly assessing sensation. You're constantly assessing circulation. Assess and document color, pulse, and temperature. Evaluating vascular status. And then the vital signs. You administer pain medicines, after the risk of head injury is ruled out. Okay, why do you think they would want to do that? Yeah, we don't want to give them anything that would further alter them neurologically, their mental status, until we make sure that there's not a problem with the mental. So we're not going to recognize it. We're not going to recognize a neurological problem if we've disguised it. X-rays and CT scans, we're going to do that pretty quick. And administer tetanus injection if the tissue trauma, if there is tissue trauma and it's been greater than 5 years since the previous one. All that good stuff. All right, other collaborative interventions. Immobilization of the fracture with a splinter cast. Closely monitor neurovascular status. Talked about that. Also assist and monitor as needed with the following. Reduction, whether it's closed reduction with manual manipulation. Open reduction, which would be surgical intervention. They have to go in and do an incision and open them up with fixation to secure alignment. ORIF. You ever heard of that acronym? It's open reduction internal fixation. So if you ever see ORIF, that means they had to go in, they had to place some type of hardware to fixate or reduce and fixate that extremity or that bone. All right. And fixation is the use of hardware, including screws, pins, plates, rods, to stabilize a fracture in the proper alignment. This is so that the healing process can occur appropriately. And then finally, traction is the exertion of a pulling force applied in two different directions to reduce and immobilize a fracture. This is most commonly done when they're preparing to go to surgery. If it's a fracture